guest speaker, he has been invited back because last time he was here, he did such a fabulous job. His name is Jay Chakrabarti, and only took, did I get it right? Yes, thank you very much. It only took me about a year. Jay is an interventional cardiologist, so for those of you that don't know, they make you all better by putting all sorts of things in your veins, like stents and things like that. He went to medical school in India. He was trained, he did residency and fellowship at Tufts in BU. He has 3 board certifications, one in cardiology, one in nuclear cardiology, and the other one in internal medicine. He is really taken up educating his colleagues in Norwich. Matter of fact, the presentation he did for my quality class last semester, he delivered to his physician colleagues and administrators at Norwich. So he really brings both the perspective of a practicing physician, which is always a good thing, but also has self-educated himself in health policy and really has a significant sophistication when it comes to health policy. So in his leisure time, which there isn't much of, he likes to make believe that your professor represents the whole trial bar and beats me up around tort reform, but yeah, other than that, he did so, but other than that, he's a very talented pianist. So I told him that we are very selective in terms of our guest speakers. We feel very privileged to have him here today. So I'm very much looking forward to his presentation and your interaction with Dr. Chakrabarti. So thank you very much, and thank you for coming tonight, Jay. We appreciate it.
Professor Maddie, thanks a lot as always. It's a great pleasure to be here. And today, I think the one important difference in terms of the last talk is that today we are talking about not only just value in healthcare, but also about the whole delivery of healthcare from conception to actual delivery to actual outcomes. So let's start off right away. Security certificate comes up. Okay, so when we talk about high performance, we have to look at the benchmarks of competence in any field, okay? So when we look at high outcomes, good outcomes, high quality outcomes in healthcare, it doesn't happen automatically. You first have to define the goal. And this is true for any line of business. You have to establish your excellence parameters. If you don't establish your excellence parameters, you really would not be knowing where you're going. It's obvious. You have to visualize what the product is, and then you have to deliver it. After you visualize it, after you establish the excellence parameters, you have to execute it. You actually have to get it done. And then once you get it done, you have to deliver it at a level of high quality. And then because the ground is always moving in healthcare, as we know, you have to have adaptability and the ability to change. Now, this is true. These 6 principles are true whether you are working in an organization that deals with healthcare, or whether it's your own personal career goal, or whether it's a combination of both. You have to have a goal definition, the establishment of the parameters that you're going to pursue. You have to be able to deliver the vision you have. You actually have to do the job. Doing the job is tough. And you have to bring high quality to it. And you have to be able to respond to change in an advantageous manner. So let's get to some practicalities. Now, these are the performance zones, okay? And throughout this talk, we will be looking at these 6 performance zones. There will be 6 case discussions. And those case discussions will be everyday, practical cases of management of the healthcare product from start to finish. So the first performance zone is governance. You have to have proper administrative governance in any organization. You have to define the product, we went through that, and then you have to defend the brand. We'll talk about what that means. You have to understand process improvement. You see, we know how to do things in a certain way, and then we get certain results that are expected when we do things a certain way. But we have to be able to measure what we are doing, and also we have to be able to improve the process, because results is what matters ultimately. You have to manage the risk involved at every stage. And by risk management, I take a broader view of risk management than just legal liability. You have to think about risk to the vision. If the ground is moving in healthcare, the vision, your original vision, may be at risk. You have to look at the risk to the brand and the product. You have to look at risk to the image. You have to look at compliance risk, and you have to look at the risk for change. So risk management, I'm trying to make you think about risk management in a broader scale than what you're used to. And then you have to be able to manage and effect change. If you can't do that, the other stuff is not worth it. So let's get to a case study. 67-year-old woman is admitted to our high-performance hospital for elective surgery of the knee. She has diabetes, high blood pressure, and arthritis. Her surgeon is very competent, and she has great confidence in his technical abilities. Surgery goes well. 21 days after surgery, she develops a knee infection. Staph grows from cultures. She started on antibiotics. She has to be readmitted for a repeat drainage and a reoperation on her knee. She's in pain, and she's upset at this outcome. So, I'll need your help here. Outcome is expected, unexpected, could be better, could be worse, or is there not enough information to judge this outcome? Any takers? Yes? It could be better in the sense that things could go smoothly, of course. It could be worse. There could be perioperative problems that are more immediate and life-threatening. So that didn't happen. Would you like more information to judge, to put this event in its context? Okay? In other words, do we need more information to judge, to make a judgment call as to whether this was a truly unexpected outcome? Well, there's a problem. We all agree there's a problem, right? The problem, main problem in this example is deficiency in governance in the hospital, deficiency in product delivery, deficiency in risk management, deficiency in process improvement, or all of the above. Take us.
I think it's all of the above.
All of the above. Why?
Because if you have proper governance and there would have been something set in place to say you're going to give the patient antibiotics prior to surgery and following surgery, which we don't know if it had been put.
So you're going to hold up the board of directors at this hospital and tell them that they don't know what they're doing?
If there's not a proper process, which would involve D, and then if they did not take those proper processes, then they're not managing their risk, and then the product that they delivered was therefore not ideal.
So clearly there was a deficiency in product delivery. There's a deficiency in perhaps in risk management, a deficiency in process improvement, but all this goes up to the issue of governance. Is that what you're saying?
Yeah, I think the hospital is responsible for the product that they deliver, and if there wasn't a process in place to manage product delivery and risk management, then yeah, they could be held liable for it.
Okay, any other views? Everybody agrees that this is a governance problem primarily, rather than, say, a technical problem. Yes?
I think you have to take into consideration risk management, because depending on the patient's current health status prior to the surgery, the impact of the surgery and the prognosis for the chances of a favorable prognosis are greatly affected by how the risk is managed given the patient's health condition.
So you're saying something interesting. You're saying that you have to look at the patient involved and see what kind of risk she came with originally for that procedure, and then look at this outcome in that context. Right?
Yes.
Okay. Super. All right, I think those are excellent, excellent suggestions. So clearly, process improvement. We'll come back to governance about this example. And I think you're right. It's a problem with governance. And yes, it's important to look at the substrate population we're dealing with when we look at outcomes, no question. So yes, it is a governance problem, but let's examine what we need to do to initiate process improvement, to make things better. So let's look at some technical aspects of knee surgery. What are the factors that determine the rate of infection in knee replacement? Okay? So antibiotics have to be given before and after surgery. Short OR time. The shorter the OR time, the better the outcome for some reason. Okay? So the quicker and smoother the surgery, the better the outcome. Minimal OR traffic, number of people passing through the OR, that's directly proportional to the chances of infection. Strict sterile technique at operating site, that's obvious, and strict sterile handling of implants that are being put in the knee. So there are these 5 things that we need to look at to influence outcome in that situation. So how do we execute this process improvement? We have to go forward and execute. So look at the number of personnel and the number of departments involved. So in the old days, you could just say, oh, this bad surgeon went to surgeon X and he operated my knee and I got an infection and look at me now. You could say that. Now I think we understand this a little better. And so we have to execute the technical factors that determine outcome, which is giving antibiotics and maintaining sterility. Clearly very important. Then we have to execute OR traffic minimization. Now think about that. That's a personnel issue. That's a workflow issue. That's an issue that deals with OR personnel management. So it's interesting that in a healthcare organization, the actual medical outcome depends on personnel workflow. So in other words, the personnel manager in the OR could be directly influencing outcome, medical outcome, by not being able to minimize OR traffic, people going in and out and in and out. And so there has to be strict traffic minimization. That's a major management issue, okay? And then we execute surgical team efficiency for reduction of OR time. Now, that's easier said than done. There are personnel dynamics. There are technical factors. If you look at the throughput of a patient for any procedure through either an operation room or for any cath lab service, it can be broken down into various processes. And each of them take a finite amount of time. So to reduce OR time, you have to break it down into those processes. So a simple case, so here I'm showing you a simple case of infection in the knee after orthopedic surgery is coming down to, outcomes are coming down to issues of not only the execution of medical technical factors, but personnel workflow and team efficiency that probably has nothing to do with the surgical skill of the doctor. So in a 21st century healthcare organization, who has the responsibility to execute this? Here we are. Hospital board, the surgeon involved, can he just do this by yelling at people? No, surgeons don't yell at anybody. The OR staff, the head of the department, the quality improvement staff, or a team of professionals who execute a process improvement protocol using a standard valid technique such as Six Sigma, Lean, with board oversight. Is that a leading answer there? Any takers? Any comments? So, number 6. Okay, thank you. So, and this goes back to the issue of what we need to do to execute that. So I think all of you realize now that to effect good outcome, we have to look at technical factors, we have to look at management processes, and we have to look at team building. And this will be a theme that will recur in other case studies that we're going to present to you, okay? So it's difficult. This is not easy, okay? So I think this should give you an idea how difficult it is to have consistently high quality outcomes in a healthcare organization. Why? Because this is hard to do. This is easier said than done. There isn't much experience in the healthcare field to make this happen as efficiently as it could be in, say, industrial engineering. Yes?
Couldn't you say that everyone on that screen has a certain degree of accountability to effectively execute?
Yes, but everyone indeed, but this choice 6 should ideally include representation from all these other categories of professionals. But I think you're right. I think the hospital board has the responsibility, the professional responsibility of actually making sure that process improvement is in place to execute this. You can't do this otherwise. You can't just say, okay, I'm going to delegate this to this doctor, and you do what it takes to make it happen. We've heard that phrase. Do what it takes to make it happen. Well, one person cannot do what it takes to make it happen because the process itself is exceedingly complex. It requires authority across departments, and it requires understanding of things that are not necessarily medical/technical. Okay? And you can make up your own examples about these kinds of processes in healthcare organizations. So yes, so primarily, I think we're agreed that this is a governance issue. And I'm very impressed that everybody understands that this is primarily a governance issue rather than a technical medical issue purely. That tells me that this class has a deeper understanding of these issues. Okay. So we come to the governance responsibilities of hospital boards and healthcare organization boards, and these are very important. I'm sure Professor Matty's taught you about compliance issues and the whole issues of compliance with regards to federal, state, and local regulations. This is kind of a recap of the governance responsibilities of boards. Very important, because you don't want board members sleeping on the job. So I think the first responsibility of a board member is to the community and then to the management. And that's something that's not realized very often. The level of disagreement and debate in a healthcare organization board is a sign that that healthcare organization is in good health. And the reason for that is there isn't a stream of yes men or yes women who are just stamping everything that management wants to stamp. Okay? So a proper setting forum for active debates about policy issues, quality issues, compliance issues is an indicator that the board is doing its job. If you see a board vote of 14-0, it either means management is fantastic or they're just rubber stamping it. Okay? So if you want to read, and that's true for any company, if you want to read a board report, and if you look at the unanimity in the voting patterns, if there's a lot of unanimity, you've got to look and ask yourself why. Okay, so when you serve, and I'm sure a lot of you will go on to serve on boards, both as part of being a member of the community and being a professional, remember that you have to speak your mind. Fiduciary responsibility was always thought to be the primary responsibility of hospital boards. And it is, okay? They have to put in their best effort for decisions regarding investment, fundraising, long-term strategy, and creditworthiness. I want you to think about this term, creditworthiness. Most community hospitals actually expand not so much by fundraising, but by issuing bonds, municipal bonds, okay? And so you have to understand how the funding, where the funding comes from, and how expansion at the local level occurs. And these bonds are locally issued municipal bonds with various prevailing market rates of interest that are paid. And so the hospital raises money by selling these bonds on the market, and then when these bonds mature in 20, 30 years, they have to pay back the principal and the interest. So the assumption is that the hospital comes out ahead because they can finance an innovation, they can bring a new technology to the community, and so the financing is taken care of. The bondholder makes a bet that they will come out ahead and the hospital will not renege. And this is a role, or this is the fiduciary responsibility of the governing board. And so the creditworthiness of a hospital is extremely important. And so when you look at the financial reports of any healthcare organization, any organization, you have to look at the creditworthiness and its ability to raise funds by raising money through bonds on the municipal market. And so this is something that you as MBA students need to understand this part of financing. Compliance issues, I won't go into a lot of detail because, yes, oh, sorry. Yes, please.
So what happens if the hospital is losing money and people don't believe in buying bonds for a hospital, and if they want to buy some kind of capital expenditure, put some money to buy equipment and stuff like that?
When the hospital is losing money and
people are not believing in buying bonds,
because the creditworthiness is not there, yeah.
how do they get money to buy new equipment?
That's a very tough situation for any hospital.
And which I think most of the Canadian hospitals are.
We are getting there in many of these hospitals. What happens in that situation, there are two things that can happen. There are 2 or 3 ways that can be managed. Obviously, your bond rating goes lower, okay? So if your creditworthiness, if you're not a creditworthy business entity, then the bond rating goes from a B plus to a C minus. So you go to the junk bond level, okay? And so the interest rate on those bonds are very high. So an uncreditworthy entity can still raise funds, and that's the beauty of the financial system, as you know, by downgrading their municipal bonds to C plus, C minus, and there will always be investing risk takers somewhere who would buy that and get the high interest rate, but the risk of reneging on the principal would be very high for that kind of an entity. Yes, but there's one more possibility before you ask. The other thing that can happen sometimes is that, yes, you can come to the end of the road and the hospital may not have any recourse. In that case, there are 2 or 3 possibilities. Either it's taken over, the worthy assets of that hospital. It's a very sad situation when that happens, and you're right to point this out. It's going to happen more and more in the next few years. The worthy assets, every hospital owns worthy assets. Those assets are taken over by another healthcare entity in the region that has deep pockets. Okay? So that hospital, so sometimes it's a loss for the community because valuable services that the community obtained locally are then outsourced to the main larger healthcare entity that took over. That can happen, or sometimes the hospital can just close. Okay, so those are the 3 unsavory possibilities when a hospital starts losing money. The other thing I forgot to mention is sometimes there can be a state interest in keeping a hospital going. And if you look at the case of Boston City Hospital a few years ago, losing money, clientele at Boston City didn't have a high level of insurance, but clearly it was in the interests of the community, interests of the state, to not have Boston City Hospital close. And so it got funded by the state. So those are the things that happen when hospitals lose money. So if you are a hospital that has a huge amount of social responsibilities, then those hospitals are usually not allowed to fail. You're too valuable to fail. You've heard that term before. Similarly, here, you're not, large hospitals do need to keep going because of the important social responsibilities. But back to your question.
So my other question is, does it affect the payment system for Medicare, Medicare, and if there are private insurance?
Whether Medicare pays...
Like if your hospital has a low bond rating, like you said.
Yeah. No. Medicare will pay whatever the zip code rate is for those procedures, as far as I know. Okay? So no, it does not affect the fiduciary creditworthiness of a healthcare entity does not influence the Medicare reimbursement rate or any reimbursement rate, as far as I know. I'm not a financial expert in this area, but as far as I know, it does not. Okay. So go back to any other questions? These are important questions. Okay. And then ultimately, the one thing that the one message I was trying to convey to you was the quality of care delivery. And that's a major, major responsibility of the governing body. Are we there yet? Are corporate hospital boards proficient at judging quality? Most boards are not yet there. So this is where education of board members and engagement of board members, not only to their fiduciary responsibilities, but also to their compliance responsibilities and the quality of care responsibilities, that needs to be ongoing. Most board members are very good at understanding their fiduciary responsibilities because most of the time their background is in finance or in law or in private business. They do understand compliance because from compliance comes liability, and people understand that well. But I think to understand quality of care is very complex. And that is where the AHRQ is going, and that's where Medicare is going, that quality of care is being tied to governance. And that example I gave you kind of typifies how that can happen and how it should happen. Okay, moving to the next. So, dual pathway of responsibilities. The management has responsibility to inform and consult with the board, and the board has the responsibility to make sure that systems are in place for compliance in the legal regulatory field as well as quality. Now, like I mentioned, legal and regulatory and fiduciary field, most boards are reasonably good. Can't assume that, but they're better. But quality of care is something that is an ongoing project. So this is something that you need to take home from today. So the hospital board has to think about making a credible, engendering a credible process improvement system. Does that mean that the board members need to come into the hospital every day and start talking to the OR staff? No. How would they do it? Any takers? I mean, how would you effect, if you were a board member, think about yourself as a board member of your local community hospital, and you've been given the task of overseeing, making sure that a credible process improvement system is in place. I think the responsibility starts with making sure that qualified people are doing the job that they are supposed to do. So that you can't expect people who cannot do the job effect a good outcome. Okay? So this is where the board comes in. The board has to understand the hiring process or the designation process. That's important. And this is true in every organization and in every sphere of life. When you delegate and designate a task, when you are delegating it, you have the responsibility to understand that the person you're delegating it to has the intellectual capacity, the management capacity, and the organizational capacity to get the job done. Otherwise, it won't be done. And so the board members collectively have the responsibility to make sure that they get the right people to do it. They don't have to necessarily get involved in the actual technical aspects of delivery of care at the granular level, but they have to understand who they're hiring and that those people are competent. So recognition of competency, very important. Okay, so any questions on governance and quality and other responsibilities of governance? Good, super. So let's move on to product and brand. This is interesting. This will be very interesting. How are we doing for time? You all right? Yeah. Okay. Colleague of mine informed me that his mother-in-law was moving from Atlanta, Georgia, to the Connecticut area, and will be living closer to them. Certainly, weather-wise, I don't know what the implications of that choice would be, but and also cuisine. I mean, imagine moving from good old-fashioned down-home Southern cooking to good old Yankee cooking. You know, it depends what you want to eat at night. But let's go over the implications of her health status. She has a history of heart failure, a prior record of a heart attack, high blood pressure, and arthritis. Very common. It's an everyday example. Okay? We've all seen people like that. So he wanted my advice regarding which doctors to consult and which hospitals to go to for the best care. Common problem? Common questions? Colleagues always asking us, regular folks always asking us, where to get your health care. My response should be, go with your current family doctor, internist. Go to the nearest tertiary care hospital for emergencies. Choose the rheumatologist approved by your insurance company. Wonder why. And consult a website which gives you all the performance information of all these healthcare entities. Any takers on this?
Probably the last one.
Last one, really?
Well, not as a blanket statement, because I think that because it's someone you know, you could probably make an educated guess about some of those other pieces of advice.
So you know of a website where we can get this information? Yes?
Yeah, there were a couple links
There are a couple.
that you had sent us.
Oh,
that
yes.
There was Angie's list.
Angie's List. Now you're scaring me. Did anybody look me up on Angie's List? Don't do that. But Angie's List and what else?
Leapfrog.
Leapfrog.
Yeah.
Okay.
And that gives you, if they're rated, I was playing around with the Leapfrog, if it's rated, if the hospitals are rated,
Yeah.
or it's not as helpful if they haven't registered that information.
So the question really is, do we have that info? Now, you wanted to say something?
Oh, no, I was going to talk about the same thing.
Yeah. Well, it's a question of information is power, right? We all know that. And so why not go to who you know, your current family internist? Why not? Yes?
Well, if they're asking you as a physician, there's actually regulations on whether or not you can recommend people based on knowing them.
No,
Usually,
people always say, go to my doctor, he's great.
usually you should recommend within a certain mile radius and put them in alphabetical order so that you don't show a preference of one person over another unless you're going by board certification and or other grants, so that you don't bias your judgment towards somebody.
So you're being really very thorough.
Yeah.
Okay, so you just won't tell your friend, oh, go with my doctor.
If
Or
they're
go with-
asking me as a health professional,
Yes.
no. But if they're asking me as an individual, then yes.
Okay, got it. Why not go to the nearest tertiary care hospital for emergencies? It's nearest. And do you guys do appendectomies? You do? Oh, great. Yeah, I'm in. Why not? I mean, isn't that what we do? I mean, do you have any control over where the EMTs take you when you have an emergency?
It's also the highest, cost of entry into the healthcare system.
What is?
Starting there. starting
Emergency.
It's in the emergency room. But if you have an emergency, you have to go to for emergency care, right? So, but ideally, you would like, even when you have an emergency, you would like to go to the entity that has the best outcomes, right? Now, at the moment you're having a heart attack or stroke, I don't think you can go online. Do not do this at home. I don't think you can go online to see, okay, heart attacks in New Haven, best doctors, okay? It's not practical, right? So again, in an emergency, it's absolutely impossible for us to get information as to where the best outcomes are. But ideally, you do need to go to, we'd all like to go to the entity that has the best outcome for that particular emergency. So this is important because this is where there's an important message in these questions, because this is where the new healthcare reform and with the current shift to value, I think we have, over the next 10 years, you'll find that these are the trends that are going to determine a high-performance organization. And so it's going to be based more on consumer choice, to some extent, to the extent possible. Again, choosing a specialist, same thing, you know. These are the information necessary to determine these, the answers to these questions is very complex. Yes?
Realistically, though, you're not, like, you should tell them to do like a bunch of those things.
Yeah.
Because if you're, like, say you're like, oh, go with my family doctor, but you have, like, mostly lung issues, and they specialize in lung issues, but
Right.
your friend has mostly heart issues, then
Correct.
your doctor may be great, but they're not going to be the one to see for
Right.
heart issues. And the websites, you know, for all their faults, might actually have some information that would be useful to them. And then, realistically, if they don't have the money and they just move here and everything else, they're going to want to go to who their insurance company will pay for.
So it has to be an in-network provider.
The best, necessarily. You know,
Yeah.
like for their routine maintenance, you know, forget the insurance or something comes up, then
Yes.
they're going to be like, okay, I'll pay for the out-of-network. But initially, they'll probably want to start with the cheapest option and go from there.
Correct. Well, I think those are all valid points, okay? So the whole point of these questions is we need information. So where do I get this data? Now, consider healthcare and consider the travel industry. Okay? If you want to fly to Atlanta, Georgia, tonight, you could go onto a dozen websites for quality information on airlines and hotels, right? You know how to do that. You could get info on mini bar rates for beer in your hotel room after midnight. I don't know why the rates go up after midnight, but they do. And then you could get info on check-in wait times at various hotels. So you could get this kind of fairly reliable information on hotel quality and on airline quality. And we appreciate that, right? I mean, we use that information for some decisions. Pricing and quality of service and customer experience. Let's try to do the same thing in healthcare, because healthcare is just as important, if not more important, than traveling to Atlanta, Georgia. So why don't we have the same information that's available to the travel industry when we're facing with literally life and death choices, and you don't have the information necessary to make the choices. So where do we get reliable data on performance in healthcare? So just ask enough people and you'll know which hospitals are good. Check the court records and find out who's been sued. Just go to the ones who've not been sued, right? Call the hospital switchboard and ask to speak to the quality information officer. Is there a person like that? or reliable information is just not available. Any takers on these? Yes? I don't see any hands. Yes?
It could be, I think the number of those things would get you the information.
Really?
Yeah.
Such as?
Well, asking people, like kind of asking around the community, because sometimes I think personal experiences at hospitals or healthcare facilities kind of reveal some information that might not be on a standard evaluation of a healthcare entity. And I think that that portion is important to consumers, sometimes more than how they rank on some of those.
So the doctor came into the room and hurried me and said, okay, let's start with your main problems, and I only have 5 minutes, as opposed to sitting down and having a long talk over 30 minutes, getting the proper history and doing a proper physical, and then getting to a proper diagnosis. What about malpractice records?
Just because you haven't been sued doesn't mean that it's not going on.
And also, it also means that if you've not been sued, doesn't mean that you have great quality. And if you have been sued, it could be a one-time thing. So it's not an indicator necessarily of quality. What about board certification status? And we'll come to that. Are hospitals forthcoming with information on quality? Quality hospitals said, okay, what are your rates for, what are your success rates for heart surgery? Well, the chance that you'll get reliable information. I mean, who's going to give you that information, firstly? Okay, so again, you can fly to Atlanta, Georgia, but you can't get the quality reports from your local hospital regarding important operations and procedures. That's where we stand in healthcare today. So, would you say 4? Well, you have to choose one. You got commitment is the issue here.
Yeah, I guess I don't think that comprehensive, reliable information is available right now.
Right. Well, I think that's right. I mean, there is the information that's available on healthcare quality that's publicly available is patchy, spotty, unreliable, not standardized, not based on a proper collection from a database that means anything. But we need to get there. And that's where we're going. Public reporting of performance is coming to a website near you. Don't know when it'll happen. I think everybody's talking about it, and it's in the works. It's being resisted, but I think the overall trend is towards more openness and access. It has to be, because we have to go back to giving the consumer the choice and the information. And that's one of the exciting things that's going to happen in the next few years. You're going to get much more information on performance, and you have to know what kind of performance information you have to ask for. Okay? Knowing to ask the right question is also important. So, there'll be state and federal mandates that'll be coming soon. These things take time. There's a process involved, but it's going to happen. Hospitals already have to publish the performance data on 3 or 4 criteria, and that's available in the Medicare.gov site, hospitalcompare.gov, where you can compare, and that's mandated. They have to send that info to the feds on Medicare patients. Okay? So there is some reliable data. Yes, please.
Do you need to worry about standard violations with websites like this that are sharing information about physicians?
You have to worry about privacy violations, you mean?
No, like slander.
Slander. Well, you know, here's the thing, and I'll come to that issue in a second, because that's an important point, and we'll come to the websites involved, and we'll talk about it in a little detail. But it's a good point. I mean, it's a good issue to raise. hospital and individual physician performance. Individual physician performance data is very, very difficult to collate and difficult to analyze and difficult to present. That doesn't mean it should not be done. It doesn't mean it cannot be done, and it doesn't mean that it won't happen. It will happen, but I think we are in the very early stages of getting reliable information on actual physician performance. Does Dr. A do better with his diabetes patients than Dr. B? Now, I mean, cut through all the issues of waiting room times, how long you have to wait for a doctor, bedside manners, stuff like that. You have to come to, I think this is a much more important question, which is, if you have diabetes, do you do better when you go to Dr. A than to Dr. B? And that's the kind of question that you'd really like an answer to. And so when we're advising somebody to go to a particular healthcare professional, particular provider, that's the information that you need to say, Dr. A does so much better with the kind of condition that you have than any other physicians in this zip code. And so we'd certainly like to go to that group. And that's the kind of information that consumers, look at it from the point of view of consumers, need to make a decision about where they want to get their health care. So it has to go back to the consumer. That's where the power should lie. Systems performance. And we'll come to these, but these are the questions you have to ask about a hospital or a health network. Of course, safety, and then actual outcomes. So these are the very, 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 very important things that you as a healthcare professional need to be aware of. And these are the criteria that you should use when you advise folks about where to get healthcare. So there is a movement currently in healthcare which is consumer-driven care, okay? And a lot of work has been done by Professor Herzlinger at the Harvard Business School. She's a real pioneer in the whole concept of consumers tailoring their own healthcare. And some of her ideas are very interesting. I think we are years away from implementing any of these, but these are all very, very exciting ideas because it puts power back where it should belong, which is consumers, informed consumers making choices. Disease-specific hospitals. Now, if you look at Cleveland Clinic, what they've done is they have now reorganized, there's a movement to reorganize departments according to disease systems, according to body systems. So Cleveland Clinic has a cardiovascular institute. Other hospitals have a head and neck institute, which means that they deal with head and neck cancers. Now some hospitals have a bariatric surgery institute. So you see where things are going. Others have a diabetes metabolic department. So we're moving from cardiac specialists, pulmonary specialists, to body system institutes. Why? Because that's where expertise can be focused. You don't deal with process variation. Everybody there who's at a cardiovascular institute at the Cleveland Clinic knows what they're doing. You're assured of high quality. And so the consumer can make a very, very informed choice. Now, all of us can't go to the Cleveland Clinic for routine care, but disease-specific hospitals or disease-specific departments that are available on a regional basis are a very, very important way of getting to good outcomes. And even in an individual hospital, you need to have areas of excellence. And that assures the consumer. And those have to be outcome-driven. The results have to be transparent. Okay? So we're moving from traditional specialists and specialties to disease processes. And that's an important move. And that's very, very necessary. And then there should be a national database of prices and outcomes for hospitals for comparison shopping. It's especially true for elective surgeries. You want to get a knee operation or a hip replaced or plastic surgery. You have no way to comparison shop, and you should be able to do that. So, and what's important when you shop? It's pricing and it's outcome. You don't want the pricing to be high and the outcome to be indifferent. You don't want the pricing to be low and the outcome to be low. It has to be just right. So the consumers will, when the information is available, make the right choice. So what Professor Herzling is doing is she is trying, instead of the insurance company directing where you go, instead of hospitals advertising and trying to entice consumers, instead, what Professor Herzlinger is doing is she is saying that information should be widely available along this scale, and healthcare entities should compete for the business just like any other business. Yes?
Doesn't this theory, though, just reinforce the over-specialization that we, as a healthcare system, have been trying to get away from? Because if you don't fit the cookie-cutter mold of one system, what do you have to do? Go to two system hospitals? The general basic care for average Joe is going to disappear into this body system related hospital.
Well, I think very good point. I think you bring up the issue of specialized care versus general medical care.
Correct.
I think those are two different problems. If you have a complicated disease process, then even a very good general process of care may not be able to get you to the best outcome. On the other hand, if you get specialized care that you don't need, unnecessary care that can be provided, and where cheaper, better care can be provided by a good general internist, that's wrong too. So I think you have to choose, you have to understand what you need. So I think there's a two-way process. There has to be regulation of who goes where, but there also has to be consumer education. And I think once you educate the consumer, and it's a tough process, I agree, but I think most people, once they're educated about the disease process, become very powerful self-advocates, and I'm a strong believer in that. And you will find, if you're an advocate for yourself, or if you get proper advocacy, I think you deserve to go to the entity that has the best specialization, the best outcome. It has to be outcome-based information. Okay, so it's not just making a specialized institute and say, okay, all diabetics now need to go to this diabetes clinic. That diabetes clinic has to show that they do better, that you do better as a diabetic if you get your care there than anywhere else. So if the outcome is better, okay, then it's worth the price, in my opinion. Okay? So value effective care is not necessarily cheap care. And this is where I think there's a lot of misconception. High-level care with great outcomes is not necessarily cheap. We cannot assume that it'll necessarily be cheap. It has to be cost-effective, but that's not the same thing as being cheap. Cost-effective means it's the best price you can get for the best outcome. It doesn't mean that there could be a better price necessarily, or that things could be cheaper. And sometimes, you can't get some outcomes cheaply. Transplantation services. Now, you could argue how much of healthcare dollars to allocate to that versus general health and so on, but that's a different argument, different debate. But I think it has to be, when you choose to go to a healthcare entity that is offering very specialized services, then I think that has to be on the basis of outcomes information that should be available. Yeah?
Don't you think that the insurance companies actually choose what the consumers have to?
Correct. They do, but if they choose on the basis of outcomes, there shouldn't be a problem. Okay? So I think you have to be fair. I think insurance companies and payers should, and we're going there, should insist on outcomes data from all providers, will be collecting outcomes data from all providers, and then they'll be informing their subscribers. Okay. In New Haven, if you go to this particular multi-specialty group, chances are, statistically, you'll get better care for these disease entities based on their record for the last 5 years. This is where we need to go. We're not there yet. But that's the kind of powerful information. And then that will make everybody better. You realize that there'll be a big scramble for the business. If there are 2 or 3 healthcare entities that are doing better, and that information is publicly available, then what happens? The others lose the business. Some people gain the business. There's immediately a response from the losers. They try to get better, and so they try to make their own metrics better. And so who gains? The consumer gains, right? Right now, it's an opaque system. You have no information as a consumer to decide. You have much better information when you want to fly from here to Atlanta in terms of the quality of your experience. But if you want to get a hip replaced or an appendectomy done, you don't have outcomes data to choose where you want to go. So disease-specific hospitals, national database of prices, and tax breaks to stimulate the choice. So so we're coming to the websites you're talking about, okay? So is there any movement towards public reporting of outcomes? So in response to your question there about websites, there are 2 kinds of information, healthcare information right now, what I see that's available on the web. One is very sketchy data on outcomes, true outcomes based on statistics. And there is anecdotal data, both are valuable, on websites, on consumer websites like Angie's List that you mentioned. Now, Angie's List and websites like that, they don't have the wherewithal to have access to meaningful outcomes data. There, in those websites, you have people logging on saying, I had a great experience with this doctor, I had a great experience at this hospital, everything was great, or the ER was dirty. This is valuable information. I mean, we like to read, hotels on Expedia.com have the same type of information. But that's not really a scientific analysis of outcomes. And that's what I think that information is much more powerful. In other words, it boils down to, would you like to go to a clean hospital that you feel good but the outcomes are bad? Or would you rather go to a not so clean hospital where the outcomes are great? Well, I think those are two unfortunate choices. I think you would like to go to a hospital where you have a great patient satisfaction experience, where the outcomes are also great, okay? And that's where consumer power comes in. And that's what we need to go to. So the Leapfrog group, this website is very, very, very important. And you should all look at it. And we talked about the whole issue of outcomes. The Leapfrog group was a voluntary program started to mobilize employer purchasing power. And what happens is that employers actually pay for insurance. And so they'd like to send their employees to the hospital or the entity with the best outcomes. So the Leapfrog group is basically a consulting group that provides information, that collects information to help people decide whether they're getting proper value for their money. And so that equals transparency and easy access. And there's information on safety, quality, and value. And this is where I wanted to do the experiment of going to the website, okay? So I wonder if we can just break a moment and put up the Leapfrog website. And we'll do an actual experiment here, okay? What I want you to do is I want us to go to the Leapfrog website and put it up on the board and look at New Haven and see what data we have. Can somebody plug it in here? Yeah.
Do you want to take a few minutes now?
Okay, we'll take a few minutes now. Yeah, we'll come back and do this experiment.
Okay. All right, so why don't we just take 5, no more than 10 minutes, okay?
And you'll be very interested in those results. All right, so we're continuing the issue of reliable comparison shopping. And so Angie's List and websites like that have important anecdotal information. But as healthcare professionals, I'm trying to direct you to sources of information that are more reliable, that give you meaningful database sourced results that can, as a healthcare professional, that you can come to some intelligent choices, okay? And so how do we do this? Well, Leapfrog Group has this great website where it compares hospital outcomes for a few major procedures. It's a roadmap. Let's see what kind of data we can get. Let's say we are in Connecticut, and we are. So watch this, Connecticut, drop down to Connecticut, okay. City of New Haven, and let's see whether we can get this data. We have great institutions here. Compare now. Okay, let's see. So what are they looking at? They're looking at St. Raphael's, and they're looking at Yale New Haven Hospital. Prevention of medication errors, decline to respond. Appropriate ICU staffing, decline to respond. So let's look at all this publicly available data. So here we are, transparency indicator, none. So if you're in the New Haven area, and if you want to make a decision, then you have no data. Okay? This is a major metropolitan area with great hospitals. And you don't have data. Okay, let's go back. Let's go back. Let's try Hartford, Connecticut. Compare now. So many hospitals in Hartford, there's got to be comparisons. Only one hospital. And they're doing pretty good. So, appropriate ICU staffing fully meets standards. Let's go back to prevention of medication errors, fully meets standards. Steps to avoid harm, they're willing to report. Reduction of hospital injuries, willing to report. That's the first step, guys. Okay? Reduce in-hospital injuries, willing to report. Managing serious errors, substantial progress. Reduce ICU infections, some progress. Transparency indicator, which is reasonable. So in the entire, two major metropolitan areas, Hartford and New Haven. There's only one hospital that's willing to report. These are important issues. Okay, this is more important data than whether the hospital floor was dirty or whether the nurses were nice. I mean, you need to know that, but this is very, very, this is hard information, okay? And I think we need, so this is clearly the proof that we need more transparency in healthcare, okay? If you go to Expedia.com and try to get hotel rooms, you'll find 400 hotels. If you go to Leapfrog.com and you want to look at data to make a decision, healthcare decision, you don't have any comparison data. Let's go back. Let's try New York, New York. Let's see what's going on there. Must be a lot of data. Let's see. Well, here we are. Bellevue, Beth Israel, Harlem Hospital reported. So that's very interesting. So appropriate ICU staffing almost meets standards. Steps to avoid harm. So you see, this is hard data. Now, each of these hospitals may have different reasons why they don't want to report it. This is voluntary. Okay? Let's go further down. Decline to respond. Look at the numbers who decline to respond. So they've all contacted, I guess. Let's go further down. Mount Sinai. Let's go further down. See? So I think you guys are getting the trend. People don't, healthcare entities don't want to report meaningful data. NYU Hospital Center. So there are some stars here, but this is where we need to go. Thank you, Laura. Yeah. Let's go back to slides. So I think where this experiment is very valuable because it gives you an idea as to what I mean by transparency and what kind of meaningful information has to be available for us to come to these conclusions. Yes?
What are some of the reasons why the hospitals decline to give information? I know it clearly impacts their business.
I think, no, it doesn't impact their what?
Their business, because, I mean, if I go into the website to prepare and if they don't give the information that
right.
I needed to look into.
Well, I think under the current situation, I think there is no incentive for a hospital to report this. You know, if the outcomes are negative, you're right, it impacts public perception. I think they may have complex reasons to decide not to report it. But I think the most important reason, the single most important reason why they decline to report is they don't have to. Life is good, and why change? So, but there's no consumer movement that forces healthcare entities to mandate reporting like that, extensive reporting like that. A leapfrog survey is a very intrusive survey of the hospital processes and what goes on inside a hospital. Yes?
The other thing is, I mean, I think it's ironic, first of all, that the places that did report scored themselves fairly high. Like,
yeah, so that tells you something, right? Yeah.
But there's no place for the hospital to kind of speak to its shortcomings. I think if it was more like, like you were saying when you compare like the travel website, they say, oh, we're 4 stars, but, or even if we're only 2 stars, here's a summary of why we're only 2 stars, but all the good things we offer.
Correct.
If there's that incentive for hospitals, they would report more. Oh, well, we don't have number 1 for safety, but here's what we're doing.
Well, exactly, exactly. But I think your point is extremely important. But again, it comes down to perception of the issue. There is no culture of transparency in the healthcare business. And whereas in the hospitality industry, there has to be a culture of transparency because of the nature of the internet and the web. So the internet and the web is so powerful, information systems are so powerful that if these entities are going to do business on the web, and that's the only way you can get hospitality business nowadays. If you don't have an internet presence, then as a hotel chain, you won't get any business. People don't pick up the phone and make a reservation anymore. Yes, one more.
Then how about the concept of pay for performance that the hospitals need to report?
Correct. We are not even at the stage where performance is reliably recorded, let alone pay. Okay? And that tells you what's going on. Now, there is performance going on. You're just not seeing it. Okay? There's no mandate to report this. And so, and this is where Professor Herzlinger's theories come in. That it has to be consumer driven. She wants a database. You see, remember that slide I showed you? Look at this. She's far ahead of her time. She wants a national database of prices and outcomes of all hospitals for comparison shopping. We tried to do that today. You saw what happened. So that's where we are now. See? And we need to go where the hospitality industry is. That's the gold standard, or the airline industry. And there's no reason why we can't do that. So,
May I make a comment?
what? Yes.
Not until business begins to realize the power they have in terms of purchasing healthcare, that they can hold practitioners and hospitals to the fire in terms of outcome data, will leapfrog really have any teeth.
Correct. And that's a great point, because Leapfrog is a group of business organizations that funded the consultancy group. So we need more leapfrogs from government and from federal mandates and state mandates. It has to be a national database. So the information has to be reliable. That's the first thing. If you're having unreliable anecdotal information, then the whole purpose is lost. No one comes out ahead. So you have to have reliable, vetted information. It has to be publicly available. It has to be transparent, and it has to be meaningful.
And they also, in my notes, I know you're probably arguing with me, but Leapfrog has to get some teeth similar to the teeth that the Joint Commission has. The Joint Commission has tied payment to sort of voluntary, mandatory participation in the Joint Commission. Leapfrog needs to do the same thing.
Well, Leapfrog is a private,
Yeah, but Leapfrog, well, Joint Commission is private too. And Joint Commission is politically smart. And
Right.
for some reason, Leapfrog doesn't get the purchasing power they
Yeah.
have and doesn't play the political process correct, similar to the way the Joint Commission is done.
Well, I think
You don't get Medicare payment unless you have Joint Commission accreditation.
Correct.
So Joint Commission accreditation is not mandatory,
Right.
but try to run a hospital without Medicare payment.
Of course. But the Leapfrog survey is probably much more extensive than the Joint Commission survey, but maybe as extensive. For some reason, but the Joint Commission data, from the best of my knowledge, is not publicly available. Either you are certified by Joint Commission or not, but how each hospital is doing as per the JCAHO is not information that you can get. All you know is this hospital is certified by the Joint Commission. So they've met certain minimum standards. But you don't have any idea what the details are. What Leapfrog is trying to do is give you some detail, but it's still voluntary. So I think what we need to do, from a consumer standpoint, we need to move from voluntary to mandatory reporting. That gives the power back to consumers. If you don't have a choice, then you have to report this data to be in business. And then once you report the data, you have to do better if you're not doing well. As simple as that. You've got to put the competition back into healthcare, and it's not there yet. So how can we judge today whether a hospital's performance is up to speed? Do you have any clues? Are there any things you can read into their publicly available information? Well, some hospitals actually are voluntarily publishing outcomes data on their website. That is important. If there's a hospital doing that, pay attention, because they're doing something right. They're ahead of the curve. Okay? It takes a lot of guts to do that, because it means that you're willing to put negative information as well as positive information out there. So you're already putting yourself and your organization under some consumer pressure in a public way. I think that's very brave. I think that's very cutting edge. That's where everybody needs to go, but some people are already there or trying to be there. Do they have an integrated state-of-the-art information management system? Or are we still writing like scribes on slips of paper? Okay? So information integration of medical care, whole new topic. We need to get there. Okay? People need to, hospital systems need to have information integration across their facility and across trans facilities, across other facilities. So if you go from one hospital to another, there has to be available information for that healthcare episode. Is physician credentialing criteria based on board certification and recertification status? Now, board certification is a standard set of qualifications, okay? Every physician needs to be board certified in their fields, okay? There's no excuse not to be board certified. And my program director in Boston had a great saying about board certification. And he said, if you're board certified, I'm not impressed. But if you're not, I'm concerned. And I think that's about right, you know? So board certification, I think recertification is important because it tells you that a physician who's graduated many years ago is still keeping up with the knowledge base. It doesn't mean that they're great doctors necessarily, but it just means that they have kept up with the minimum necessary to keep up their knowledge base. And that's important. There are many views about it, recertification. And the New England Journal of Medicine recently had a whole edition devoted to the issues of recertification, pros and cons. But it helps to know your doctor who graduated in 1975 when the Beatles were still singing, has recertified in internal medicine. It's good to know. Yeah, it's this. So do they publish patient satisfaction reports on their website? And do they have process improvement systems and safety systems in place? And that's absolutely connected to integrated information management and how robust is staff education on safety. So is there awareness and emphasis on safety? Again, going back to the issue of governance. So these are all indirect questions of governance. So you're probing governance. So look at their annual report. There should be, in this day and age, there should be a report on what the board is doing for safety. So if you want to look at a hospital's performance, look at outcomes data that they may voluntarily be publishing, call them up and say, why can't I have outcomes data on heart attack rates or on stroke outcomes? There has to be public pressure. Do they have an integrated state-of-the-art information management system? You can tell by the way care is given. Physician credentialing is on every website. You'll know who's board certified and what. That's publicly available information. It may not be as reliable as you think for indicators of quality, but it's there. Patient satisfaction reports on website. It's a plus minus. It may or may not be there. And if you look at the annual reports, you should be able to get information on their quality management systems. And that's from the board. So yes, even now, you can judge a hospital's performance potential. How to judge a physician's credentials? Oh, you're choosing a doctor. Remember that was the original question. No reliable data for individual performance yet. There's Angie's List. The doctor was nasty to me. The doctor was very sweet to me. The waiting room was full. The waiting room was dirty. The waiting room was clean. You have anecdotal information on that kind of stuff. You have no information on individual performance for outcomes. Board certification, recertification, you do have info. National Practitioner Data Bank. This is a data bank that's where egregious deviations from standards are reported, not open to general public. And informal reports from websites like Angie's List, which also profiles plumbers. So it's important. Next case. Statewide surveys taken by state authorities regarding the prevalence of MRSA infections after hospitalization at all hospitals in the state. This is fiction, by the way. Two particular hospitals stand out. Hospital A has a very low rate of post-hospital infection of staff. Hospital B has a very high rate and is considered high risk and unsafe. So what's going on? What are the risk factors that determine the transmission in the hospital of methicillin-resistant staph, which is really a bad bug to get? Antibiotic use in the last 3 months, hospitalizations in any hospital for the last 12 months, skin or soft tissue infection, HIV infection, open wounds, invasive devices in place, and patient from long-term care facility. So those are the risk factors. If you have those, your index of suspicion should be up. So you've just been appointed to improve quality of care at Hospital B. So here's the office, very nice carpets, but do you want to touch anything? Maybe not. Your first move, close the hospital. It's been done. Tell everyone to wash their hands every hour on the hour. Issue a public statement denying the problem is not really that bad. Happens all the time. Yeah, it's an exaggeration of the problem. You have a press officer who can do that, right? Or start measuring the extent of MRSA infection, or observe the ergonomics of care on the hospital floors and ICU and visit Hospital A. What would you do first? Any takers? Tell everyone to wash their hands. Yes? And somebody needs to raise their hand and yes.
I think people should be washing their hands a little bit more than every hour.
Wash their hands a little bit more, yeah, than they are, yes, I agree. Soap and water. Any other takers? Yes?
I go with E.
E. Observe the ergonomics of care on the hospital floor and ICU and visit hospital A. Why not start measuring?
You have to figure out what they're doing first. So that
Right. Right. Why? Because what they're doing may be influencing what's going on. And so, yes, somebody else wanted to speak.
No, I was going to say D.
D. Well, start measuring. Well, you know, it's already been measured. Hospital A and Hospital B has already been measured, and you're doing badly. Okay? So, some people will say, okay, let's remeasure it. Well, it's not useful. But yes, I think E would be to observe the ergonomics of care and see what your nurses are doing, what your doctors are doing, what your patient care technicians are doing, and what your patients are doing. So what is ergonomics? The science of designing the job and the equipment in the workplace to fit the worker. There has to be ideal balance between human comfort and systems performance. You can't make a worker uncomfortable and expect good results. So you've got to fit the place, the person, and the job. And the ideal goal is to reduce the effort it's necessary to comply and make it impossible not to comply. They're two different things. Okay? First is make it easy. Second is make it impossible for people not to do the right thing. In other words, you have to introduce redundancy. There's no way you can not wash your hands before you enter the patient's room. Can you devise a system like that? And then you have to make it easy. That's the principle of ergonomics. And I think this is a very complex but very important case. A lot of take-home messages here. So what do we need to do? So it's a tall order. What do we need to do to reduce MRSA hospital transmission? There are 10 things that you may have to do. And so it's not just hand washing. It's not just telling people to be more careful. It's not just telling people to do the right thing. It is creating a system to identify and track the patients, educate providers and patients, practice good hand hygiene, contact precautions for MRSA infected patients, dedicated equipment for MRSA infected patients. Nurse goes into the BP cuff, takes the same BP cuff to everybody else on the floor. Guess what? Everybody else has MRSA. Right? So, you think about equipment, stethoscope. Doctor goes in, the stethoscope. Here's the patient who's infected with the staph. Goes to the next patient. Mrs. Smith, how are you today? Mrs. Smith gets the MRSA from the patient next door. So doctor's stethoscope. You mean I have to take my stethoscope off to see this patient? Yes. So the change of culture. So stethoscopes, blood pressure cuffs, all equipment has to be dedicated for the MRSA infection. So it's expensive. Environmental decontamination, the patient leaves. The room has to be measure the incidence after that. Provide the feedback to providers. Dr. X, you went into that room, you barged in, you didn't see that sign that said stop and change your clothes, put that gown on, put the glove on, and take your stethoscope off. Give them meaningful feedback. Active surveillance if MRSA is still not controlled. Got to look into the people you're missing. And then lastly, consider decolonization and active surveillance. So you've got to have the science right. But even if you know the science, and if you know what it takes, and if you know all 10 things that need to be done to improve the quality, even then, you have to do something else. What do you do? So you see the 10 things we need to do. Let's just do what is doable. A lot of people do that. Let's do number 2, 3, and 4 and see what happens. Why do the whole thing? It's just too much time. Let's not upset the whole thing and just let's do what's doable. You've heard that before? Yes. Tell people to do their personal best and make sure you nab the worst offenders. Let's find out who are the guys who are not performing well. Let's give them bad report cards. Well, yes, but that's not going to solve the problem. So, you have to convene a process improvement team. So this is where you have to look at the 10 things you need to do, and then you have to figure out how to improve the things, incorporating the 10 things. So you need a team. Again, it comes back to team. It's not the doctor, it's not the nurse, it's not the administrator, it's not the board. It's a team using process improvement techniques. So let's get a little technical. Six Sigma or Lean, what do you want to use? Six Sigma because it sounds much more technical, right? Lean, Toyota uses it. See what happened to them. So, any takers? So I want to see a few hands up for this. Yes?
I think I would go with Six Sigma.
You go with Six Sigma. Why?
It was designed to get rid of ineffectiveness and increase effectiveness within the corporation. Like, I read an article the other day about GE when they started using it.
Yeah.
And they increased revenues and effectiveness by like hundreds of times. So
Right.
I would think I would go Six.
They would use that. They would look at each step and then improve the violations. They would reduce the violations and improve the quality at each step.
And it's been proven to work, so I think I would go Six Sigma.
All right. Any other views?
Can you describe the difference
Between Lean and Six Sigma, the difference between them? Well, Six Sigma basically looks at every step. If you're making, say, a widget 1,000 times, there's always be a few that are defective. So what Six Sigma does is it tries to make the process as efficient as possible so that it reduces the mistake at every step to a minimum. That in short is Six Sigma. What Lean does is it kind of evaluates inefficiencies in your system and eliminates waste. Everything you do, everything we do, human endeavor has waste incorporated in it because we don't do things efficiently all the time. We have to think about efficiency, but it doesn't come naturally. So what Lean does, it looks at waste and how to reduce waste. So that's an essential difference. But there are further slides that explain that. Any other takers on this question of Lean versus Six Sigma? This is important. If you're going to do process improvement in your healthcare organization, you'll have to understand the difference between the two, and you should be able to figure out how to approach, how to decide which one to use. So I'd like to see more hands. Yes? No? No opinion?
Well, I mean, I guess I would agree. Oh, are you talking to me?
Yes, I'm talking to.
Okay. I didn't know who you were.
Yeah.
Okay, go ahead.
I guess I would choose to use Six Sigma.
Six Sigma too.
Because you can see where
Right.
the problem is. 'Cause it
Yep.
may not be step A,
Yeah,
but it
yeah,
may be
yeah,
somewhere
yeah.
along the line.
Okay.
So I would use Six Sigma.
If we talk about wastage and all, I think Lean is a good
Wastage. What's wasting? What's wastage here?
reduction of the waste.
Okay. So MRSA, so in this example.
Right. Oh, and I think that.
Yeah.
Six Sigma is better designed to handle this.
Because it's multifactorial, multivariables. Each step has a lot of defects, violations. You reduce that to a minimum. You figure it out where the problem is and you nab it, right? That's what you're saying. Okay. Excellent. What about this thing? Good hand hygiene. I just want you to think about good hand hygiene. Visualize it. Nurse or doctor goes into the room and presses that lotion bottle and then goes in. Comes out, presses the lotion button, gets out. Right? That's good hand hygiene. So if the lotion bottle is in the same place every time, you reduce the effort it takes to comply. and you make it impossible not to comply. So it should be on the, if you're right-handed, it should be on the right side. As you go in the room, boom, and you go in, hello, Mrs. Smith. It's like one movement, and becomes part of your daily routine. It's become automatic. You don't think about it. So you're washing your hands as you're going in the room because it's right there, and that's what you know to do. So it becomes part of your daily routine. So I want you to just think about what I said, and then we will go into Six Sigma and Lean again. Six Sigma and Lean. So you have to obviously define the nature of the problem that will define the solution to the problem. Or they're all the same. Use anything that works. Define the problem. The main problem is to reduce infection rate by increasing hand washing. True or false? Be very careful when you answer this. I need some takers. People are getting shy here.
False. That's not the only means by which you're looking to reduce.
Main problem is to reduce, yeah. So it's false. It's false. Yes, the main problem is not increasing hand washing. So let's answer the question. What's the problem? The main problem is to reduce infection rate by influencing multiple variables. We decided that was true. The main problem is we don't know what variables to influence. True or false? False, yes. We know what we need to do. We know the variables. You saw those 10 entities in that slide, okay? And there's a high cost to this infection rate? Yes, cost is huge. So it's not hand washing. So what is it? What is Six Sigma? To answer to your question, it reduces process variation. So 1,000 doctors, one doctor going into a room 1,000 times. How many times will he remember to wash his hands? Six Sigma requires that deficiency rate should be no more than 6.2 per million times he goes in. That's the standard of quality we're talking about, okay? So we're never going to get there in healthcare to those levels of industrial quality. So this means that if 1 million doctors are going into the room, no more than 6 should have a violation. Or 1 million nurses. That's a huge standard to meet, okay? But that's what Six Sigma does. It basically calculates how many times you've made a violation of the rule. So say I'm a physician at this particular hospital. I've been told by the quality and safety officer, you have to wash your hands every time using that lotion you go into a patient's room. And I have to do it every time. And suppose I have been given a sensor and I'm being measured. So if I am Six Sigma compliant in that process, my deficiency rate should be no more than 6 per million times I go into a patient's room. That means I'm perfect. And that's not going to happen. So, but that's what we're looking at. So it can eliminate, so everything you do, no gowns, you're going to wear a gown, again, do it 1 million times, no more than 6 deficiencies. Surveillance cultures, everybody gets that, no more than 6 per million. Eliminate so DPMO rate. So the one thing you want to remember in Six Sigma, DPMO, it's a cool mnemonic, defects per million opportunities. So every time you do something by a certain rule, it's the number of times you violate that rule. And so all those 10 steps, you start making Six Sigma rules for each of those things. And this, you realize you can use in any project you're doing in your own organization. Take a project and see how you can apply Six Sigma. And say, okay, I'm not going to violate this rule. I'm going to use Six Sigma. You'll come out ahead. So it can directly measure the business cost advantages. So that's Six Sigma. Lean, on the other hand, process inefficiency analysis. And so this is from Toyota Production Systems. And they say that there are 7 types of waste in anything people do. You're making a product. Waste in overproduction, underproduction, both are wasteful. wasted inventory, reworking, wasted motion. Remember what I said about hand motion. Hand washing. Strike a bell. Wasted motion. Waste with waiting, waste with processing, and waste from transport and handling. Those are all industrial stuff. But this is something that interests me. Why? Go back to the MRSA issue. Remember what I said? Pushing that thing, getting the room, coming out, pushing the thing on the way out. If you have those lotion bottles in different parts of the room, one patient room has it on the left, one patient has it outside the bathroom, one patient has it on the left side, one patient has it can't reach it. What happens to the person who's trying to comply? It's tough. I'm spending time looking, where is this hand lotion bottle that I want to do well, I want to do good, I want to attain the high standard, but you have to make it easy for me. So if I know it's always the same place, boom, in, out, done. But if you are floundering around, wasting time, looking at, trying to see, locate it in 100 different rooms you have to visit every time for different patients. If it's not the same standard place, what's going to be your Six Sigma rate of compliance? Low. Why? Because you'll forget, you'll lose interest, you won't have the same reflex, and you won't be able to incorporate that in your daily routine every time. Habit is the best way to comply. So see how Lean and Six Sigma are getting connected in our project. So a lot of people said, oh, I want to go to Six Sigma. It's a good reflex, but there is something that Lean can help us in this situation. So what should we use now? Let me ask the question again. Both. Right. And now you can see why. Because Six Sigma gives you defects per million. Lean makes it easy because it reduces the inefficiency in what you're doing. And so to have a successful plan, you have to do both. So solution requires steps. You have to define, measure, analyze, and improve and control. Your team has to look at ergonomics. So Lean is required for hand washing ease. And so the combination of a Six Sigma business plan with a lean-based ergonomic reduction or wasted motion plan is what will get you there. So reduce wasted motion. Providers should come into and out of the room pushing the lotion bottle effortlessly on entrance, even without thinking. Automatic repeat motions are the best. Gowns should be ready at the entrance, and patients should be made aware. Doctor, have you washed your hand just now? I've had a few patients who asked me that, and it's a shock. But I think going back to consumer awareness and the whole issues of advocating for yourself, it shouldn't be a surprise. I think people should speak up and say, doctor, have you washed your hands? And that question should also be asked the hospital, do you have an information system in place? So this is consumer awareness education. You can't have enough of it. You've got to have more. 66-year-old patient, case 4. Comes to the ER feeling dizzy. ER doctors evaluate her, say she's doing fine, and everything seems to be fine. She underwent EKG monitoring, but she wishes to leave. She's admitted by the attending hospitalist. And then we find out that she was having hip replacement at another hospital. She's done well, and now she has very little pain at her operation site. But she started feeling very tired. Her blood pressure went down, and a CT scan showed that she had a pulmonary embolus. So, started on treatment, made a good recovery, remained mildly short of breath. And then we got further information. So on discharge, she had to go on blood thinners, obviously, because she had a clot to the lung. Further information regarding her post-operative state. She apparently had got blood thinners after hip surgery from the other hospital. She did not get blood thinners when discharged from that hospital, and the rehab facility that she went to did not get the order for the blood thinner or did not implement the order if they got it. How common is that? Much commoner than you think. So what's the nature of this problem? Any takers? Substandard care on the part of the surgeon, lack of communication, integration of care, lack of patient awareness, or all of the above. Lawrence has all of the above, and we agree. So you see, this is where risk management and quality interface. What you need is an information system that integrates across the delivery platform. You get discharged from the hospital, you go to the nursing home facility, the communication system breaks down or can break down. Vital drugs can get missed. Bad outcomes can happen. So how do you judge a high quality information system? It has to be integrated, like we talked about. There has to be intelligent interactivity. The program needs to tell you, oh, you're discharging the patient after hip surgery. Have you given DVT prophylaxis? Little pop-up. Makes life simpler. Safety alerts, patient compliance alerts. Doctor, you prescribed this, but hey, the patient's not refilled. Pharmacies now do that. I don't know if you guys know that. Pharmacies actually call me up. They still can't send a pop-up. They call me up and say, oh, but this medication you wrote for this patient, he's only filled it once the last 2 months. And you didn't fill the refill. You know your patient's not taking that medication. So information integration. And ultimately, I want to present a case of asthma, again, very common, where a 45-year-old lady comes with a prior record of allergy and asthma, comes to the local hospital, ER. Over the last 6 months, she's been in the hospital 8 times. Gets better after a few days, and then she's back in the hospital in about a month. What happens to the healthcare system? Huge cost. Not getting better, getting depressed. Providers and hospitals are billing her insurance on a repeated basis, increasing the cost, and there's lost productivity. So everybody's losing out. So any takers? Choices. A, it's patient's fault. B, it's the doctor's fault. Situation cannot be changed. Or anybody believes that this is not the right way to go about doing it? Current delivery, where somebody gets sick, gets better, gets sick, gets better, gets sick, gets better, raises cost. There's no incentive to create a provider network that delivers value there. So how can we change that? Professor Michael Porter, and this was dealt with in my value class previously, but basically you have to create an incentive to align the whole episodes of care. You can't take things discretely. You have to pay for the integrated care, and you have to create an incentive that the entire team gets reimbursed for a good outcome, okay? And that's the way to go. So what do we need to do? For our lady with asthma, we need to develop a local integrated care delivery system where there is an asthma chronic disease management program. We come back to the issue that you're talking about, which is, should people with high-risk disease entities, should they go to specialized programs? This is your answer. They should. Why? Because they do better. And there's huge cost to the system if they keep going back and forth to the ER and the hospital and back and forth. So if they go to a chronic disease management program that has good outcome, that works, they have to deliver the goods, then they should be paid for preventing the hospitalization rather than high-intensity hospital care. Team building, final case. And this is at an insurance company. You're working as a program director for diabetes integrated care at an insurance company. One of the problems we identified is repeated testing. Everybody's testing blood these days. Cholesterol, blood sugar, blood chemistry. And are all the providers getting these blood test results? It's an information problem. Unnecessary testing. I don't know what the primary care physician has ordered. The primary care physician doesn't know. I've ordered cholesterol. Patients going to one lab when they're coming to me, another lab for the primary care physician. Duplication, unnecessary testing, and risk and liability if there's poor communication of abnormal results. So these are the costs. This is the nature of the problem.
Before you go on, may I ask a question?
Yeah.
Why isn't just normal procedure duplication counted as a Why do I always have to fight with that?
It should be. It should be. You should just be able to have access to.
Right, because this sort of diminishes some of the issues.
Right. Patients should be able to bring you the. But at a wider scale, there should be an information system that helps you access all the data.
But we both know that doesn't exist. So
Right.
when I was trying to figure out what was wrong with my daughter, I created a medical chart myself
Yes.
and walked it around
Right.
because of this reason.
Yes.
But I had to fight with them constantly to give me a copy of the
It
blood work.
requires a very motivated consumer to do that. It requires an educated, informed consumer to do that. And it requires some measure of being able to speak up at a healthcare facility and a doctor's office saying, "Doctor, can you give me a copy of my results? Sign here, sign there, sign everywhere, but you'll get it." Okay? And so, yes, the really informed consumer who now knows how broken the system is actually does what you did, which is make copies of everything everywhere and bring it to every doctor they go to and every provider they go to. But everybody doesn't have the information or the insight or the drive or the consistency to do that. And that's where we are failing them. Okay? The ones among us who are better informed, who are in the system, they know that communication among your providers is very important. But I think the problem should not be put on the shoulders of the consumer. We should be able to provide that service on a daily basis. So how do you do this? I think you have to build a team here that can develop the proper communication techniques across the delivery platforms, either through provider alerts, and you have to measure the cost before and after, and you have to develop a system of alerts. So the insurance company is the one that's paying, so they have the most incentive to change that situation. One of the techniques that's used is not pay unless it goes to the primary care physician. We know that doesn't work because it creates a lot of frustration in the system. But I think consumer awareness is important, but also having an integrated delivery platform. And this is where a high-performance team-building principle comes in.
Jay, but won't a lot of these issues be eliminated if we were to just adopt widespread use of EMR?
I think, but EMRs need to talk to each other. You see, one of the problems that I've encountered is that there are now, after the administration has created incentives for providers to go to electronic medical records, hundreds of providers of EMR systems have popped up. This has become a cottage industry. There's a certification to make sure that these entities meet the proper standards. But one of the things that's not happening is EMRs, different brands of EMR systems talking to each other across a hub. In other words, if you come to the physician's office and he has a state-of-the-art EMR system, gets all your records nicely put into the system, you go to the local ER. Your local ER has no access to the physician's records. And so they repeat everything. You had an echocardiogram last week, here's another. If you had a blood test last week, here's another. So there is a HIPAA issue here as well, privacy, but I don't think that's the main barrier. I think the main barrier is technical. These EMR systems need to communicate with across a hub. And mandates come in here. The EMR providers need to be mandated to make them intercompatible. So one major provider can speak to the program of another major provider so that we don't have these. So the ER can dial up my office and say, let's dial up. We can give them access. Somebody is on call 24 hours a day at our practice. We can give them access and say, okay, we'll give you access for this patient. This is the patient's ID. And you can dial up that patient's record from our information database. Why? Because on an emergency basis, that patient needs to have that information delivered. The technology is here, but the barriers are, they're systems barriers. There's cultural barriers. There are incentivization, there's wrong incentivization. So all these things will get better, I hope, as we move along the next 5 to 10 years. But but I think we are starting to understand what these challenges are. And those who understand healthcare now, I think we have to understand how complex this whole process is. So team building is very important. But when you build a team, one of the things you have to do is to clearly define the project outcome. And you cannot change the project outcome and your success criteria midway. We know we're not going to get to that Six Sigma goal. Let's change it a little bit and we can declare success. You have to resist the temptation to do that. You define success and failure before you start the project. You should have high standards for yourself. And teams should disband, leaving behind a systems-based model to continue to be effective. So you have to make sure that something permanent, you left something permanent in place that is better. That's the whole point of it. So here are your final principles. Last 2 slides coming up. Time for dinner. Final principles of operation for high performance in healthcare. Clarity in governance. We all know that now. Define your healthcare product clearly. Specialist, generalist, tertiary care. Don't let the product chase you. You have to be ahead of the curve here. Defend the brand. If you want to go for transparency, let your organization go on leapfrog, publish it, have the guts to do that. Develop your brand, and come out ahead. Set up process improvement. Have to do that, otherwise you're blind. You can't just go on without data and without a proper specialized way of looking at that data and to improve the outcome. Ethical integrity in data management. You really have to collect good data that can stand up to the light of day, okay? And you have to anticipate change. This is an article that all of you should read in the Harvard Business Review of this month. And I think we went through most of these today. But it's a great article written by Morse, and basically these are the 10 things that are coming in healthcare in this decade. Checklists. You have to go through everything before we do something as a procedure in a healthcare entity. Behavioral change induction, how to change patient behavior, how to change provider behavior, another important entity. Various ways, incentivization to do that. We talked about lean, we talked about wasted motion or lack of wasted motion. What is that? That is basically changing provider behavior for a better outcome. Okay? So behavioral change incentives is how you get to better outcomes. Patient portals. This is coming. You should be able to go on your provider's website and make your own appointment. You should be able to get a list of what the slots are, what your availability is. You should be able to put yourself in and say, okay, I want Thursday afternoon at 2 o'clock, or Friday afternoon at 4, or Monday morning at 10. There are 3 choices. Pick your best choice. Boom, boom, boom. Enter. You should get an email within 30 minutes saying, here's your appointment. Is it doable? Yes. Is it going to happen anytime soon? No. Why? Okay? So, patient portals, they're coming. It can happen, and it will happen, because the providers who are going to be ahead of the game, when they're incentivized, they will create these portals for you. Payment innovations, we talked about that. Paying for integrated care rather than discrete care. Pay for performance. Evidence-based decision making. Believe it or not, still doesn't happen. Needs to happen. Accountable care organizations. These are organizations of providers who need to band together to provide the best care and the best outcome. The new health reform initiatives are incentivizing, will be incentivizing providers to get together in groups. They don't need to be in the same building, but they need to be in same entities that will provide coordinated, integrated care. And that will give us the best value for the healthcare dollars invested. Virtual visits. You have high blood pressure. Do you have to go to the doctor every time to change a medication for tweaking your blood pressure? You're taking blood pressure at home. You made a list. Do you need to go to the physician's office every time to tweak your blood pressure medicines? That's 6 visits in 3 months. No. There's no medical reason for that to happen. A lot of this can be done effectively and safely on a virtual visit on the web with an informed consumer who can access the web and who has the technology savvy, who's technologically savvy to do it. But there's no payment for that model yet. There's no insurance company that will pay for that encounter. So that's coming. You'll be able to help 20 patients more. Look at the time involved. You can do this in much less time than in a waiting room, and you can come to the same outcome. And then the last 3 are still in the realm of speculation, which is stem cells, which will really change many disease processes. Surgical robots are coming. There's still not a movie about this yet, but I'm sure along the lines of Transformers. You've seen that movie, anybody? And genetic medicine, which is individualizing your medical care based on your genetic makeup. All drugs are not for everybody. Now we know that there's a reason why some people react differently to different medications. And the reason often is the way these drugs are processed in the system based on their genetic makeup. Right now, the basic science of that is still being worked out. You're still getting there, but that's coming. And so they will come when we'll take your blood, run a gene profile and say, okay, this antibiotic will work best for you, this won't, this blood pressure medicine is going to work for you, and here's your list of preferred medicines based on your genetic profile. It's a few years away, it's a few decades away, but that's coming. So you'll be able to avoid allergies, side effects, unintended consequences and all the costs to the system that arises from that. So that's something to think about. Okay? So 10 transformations and 6 cases. I think you guys are ready. Thank you. Thanks.